My name is Ros O'Leary. I am a periodontist. I work in London. And I have been supporting Siobhan in the Ikigai series of lectures and hands-on in 2021.
Thank you, Ros. Hi, everybody. My name is Siobhan Kelleher. I'm a dental hygienist, a qualified coach, an Ikigai educator, and I also coordinate the Ikigai oral hygiene program. Well, we got out and about last year, Ros, and it was great to have the live sessions, wasn't it? How did you find them?
Well, I really enjoyed it because they were one of the first, face-to-face meetings that we had for like nearly a year and a half to two. And you forget just how exciting being in a room with people in a kind of learning environment, but also kind of a community, and you chat to people and you learn, and it's absolutely stimulating. And I thought they were a joyous occasion, actually.
Different to before. And do you think it's because it heightened our awareness just how special it was to get into a room and network and share our stories really from the last couple of years?
Oh, I agree, because you take for granted. We've always, trotted along to meetings, met people. Sometimes we go out of almost duress. So this was very much an elective process. We went there and it was new and it was exciting, and it kind of felt good to be back to our old life in a way. And I suppose, like everything, you don't know what you missed till it's gone. And this was definitely a case of, I really miss meeting other people.
Absolutely.
Such a good environment. Yeah.
And our aim has been to support dental hygienists and therapists, and we also have dentists coming on our courses and involved in our webinars. The aim was really to give that support, so to upskill, in hands-on instrumentation, and I suppose emotionally to have that support network around as well, because although COVID has heightened awareness again around that we all need supportive networks, really in dentistry up to a few years ago, there wasn't really anything like this. And the reports that are coming back in from the evaluations are saying that it's very important. Did you feel that on the courses? Were you getting that kind of feedback?
Well, I mean, I've thought a lot about it since then. And one of the things I feel about hygienists is that hygienists sometimes take too much responsibility. They feel they should be able to do everything. They feel that despite not having sometimes enough information, radiographs, et cetera, that somehow or another, they should be able to be all things to all people. And one of the aims for me is to try and make them feel that they are very much part of a team, and that they also need to reach out to other members of the team. If you want to sort of really look after people, it is very much a team effort. And so it's to give people confidence to be able to say, yes, this is the situation, this is what I can do, I might need something else. And if you don't have a confident workforce, they tend to be reticent about really kind of demanding what they need to be able to provide the service that the patient wishes and they wish to provide. So by meeting other people and talking to other people and going to the lectures and doing the hands-on, they increase their own knowledge, but again, their confidence about where they sit within their profession, how they can expand their knowledge, how can they do things differently, or how they can do things better. And that's what I felt was really the crux of the meetings. And that's why I feel that it is very much a process for their development. And as you say, upskilling, all of that kind of thing. But if you are confident in your position, you make better judgments than if you do things out of fear or not wanting to bother people. Do you understand what I mean?
Yes, I do. And what you're saying there about, the communication or not taking on the full responsibility, it can be quite difficult in practice, because I've worked in several different situations. And, I know when I need to go back to a team member or to a principal or associate and say that this is beyond my remit, but often met with resistance there, Ros. So,
yes. Now, and again, it like everything to do with team working is team working, and there are different personalities, and we all have to navigate how to deal with different personalities. But if you are sort of professionally aware, if you know the rules and regulations under which you are governed and which you will be judged, if you are confident in that and you are you know what you can do, you can then more easily discuss with other people from a sort of almost a medical legal perspective, which isn't really how you want to do things. But if it comes to that, you have to make people aware that this is how this case will be judged, and certain things are missing, and I will need support. It doesn't always necessarily mean that you can't deal with it. It's just like, do you have enough radiographs? Do you have enough time? Do you need the support of, what other kinds of support would you need to manage this patient? It isn't always that it's outside your remit, but you shouldn't be asked to work with your hands tied behind your back with no radiographs or no time to do a charting or, all those kind of things. But
yeah, time is huge.
Time is huge. Time is huge.
Often when I joined a new practice and I could see, there was no systems or protocols in place, I would ask for them to call a meeting, just in a very nice way, and just say, look, I can see how we can do things a little bit easier here. And just spend that time to educate the team and say, look, we need to call appointments certain names. We all need to know what's going on when we first look at the book, because sometimes there'd just be a book full of 30 minutes, no differentiation between maintenance, supportive, therapy. And just to even educate the team around that, I used to find was very helpful. It wouldn't always work out. And often, for whatever reason, people don't come on board, but in general, they do when you open up and educate the team.
I agree. And I think that, you can try and force people, but it's never the way to work. It's never the way to work as part of a team. But if you can educate the team and impress upon them the importance here of treating patients effectively. Of course, time is always a constraint, and we all work under that. But as you say, if you have a book full of 30-minute appointments, and some patients take 10 minutes to get in the door and out the door, it's like, where are you left with the time to be able to deliver the care? And I keep saying, if this was your sister or this was your mother or whatever, is this how you would want them to be treated? And within the limitations of time, you will only feel proud of yourself at the end of the day if you feel that you have given people the care that they deserve or think they're getting. And so that is it, and it is a challenge for sure. But as you say, calling appointments, different things, and trying desperately to move away from this 30-minute thing.
Oh yeah, absolutely. And given more time, and even for the clinicians themselves, their back and their shoulders and everything, yes. It's hard work doing every 30 minutes, isn't it? Also from the patient's point of view, if you can build value into that appointment in the education, getting the radiographs out, showing them the yes. whole thing, and co-creating that appointment with the patient. I've never had anyone turn around and say, no, I won't have that 45, I won't have that hour appointment with you.
I think that when patients think that it is all about scaling, that sort of concept of just get on and scale my teeth, if that's their vision of a maintenance or a hygienist appointment, then it is very challenging because they're not valuing your role. But I suppose it is your role to try and educate them, to make them understand that actually that is only a part of the role. And I mean, oral hygiene instruction itself takes ages.
Absolutely.
And so if you have even say you have a 30-minute appointment, that's a 25-minute appointment. If you're going to do any kind of decon, this is even before COVID, and it's 5 minutes to get a patient in and out the door. So you're now down to a 20-minute appointment. So, I mean, if you sort of think about it, oral hygiene instruction for lots of patients takes 10 minutes. And assessment is going to take a minimum of 5 minutes. So theoretically, if you were to do that, that leaves you with literally 5 or 7 minutes to do the so-called scaling. And you can see that the balance of the appointment is completely wrong. And it is also taking away the responsibility from the patient, because it's you're doing, you're scaling, you're doing the job. Whilst it should be, I'm helping you, I'm going to clean your teeth, I'm going to scale this, I'm going to do this, but your role in it is actually more important. And ideally, the appointment should be managed that way. But of course, you know, everything is a compromise.
Yeah, I certainly agree. Just going back to the courses and the hands-on and the various piezo tips, because I know when I qualified, we had one small kind of chunky little ultrasonic tip, and then we relied on hand scalers. And it's amazing how time has moved on and these fabulous tips that we have. What did you think of the various tips we were using?
Well, I thought, no, when I did my dissertation 100 years ago, I did a dissertation on ultrasonics. So I thought I knew about ultrasonics and ultrasonic tips. So I was kind of aghast at my lack of knowledge and my lack of understanding, one, about how they actually do work and how much time we waste using these things, these tips incorrectly, the wrong part of the tip, the wrong angle, you know, so, you know, and then we're leaning into it when, of course, you should never do that. So I was fascinated to realize that I don't need to be putting half the elbow grease into the thing at all for it to be actually working better. So that was the first thing I learned, is positioning tips and how you visualize the tip around the root. You know, different parts of the roots are concave, different parts of the roots are convex, some parts are flat, some parts are incredibly rounding. And yes, the one size fits all is therefore going to be incredibly challenging. The thing I liked about the course is that you pinned it down to a few tips, because it is a total minefield, the situation of tips. I mean, there's so
about
many.
70, about 70.
That's too much choice for anybody. It's too confusing. And also the similarities and differences between lots of them must be so small that we may not necessarily really understand. So by narrowing it down to how many did we have?
We had about six. 5 to 6, yeah. So we had 16 educators and we all like various tips. So we all got together and we decided to put what could work for a full mouth debridement, and then our maintenance. So we have the G tips for general and the P for perio, and that's where we come up with those. But it really worked, didn't it? I do think it was really successful. I really, and as I said, for people like me who really thought that they knew it all, it was quite enlightening to realize that, no, you don't know it all. And actually, isn't that another thing about going to any course, especially kind of hands-on? Even when you go there thinking that you know it all, you will often come away with new snippets of information. And even if they're just a few things, they can make such a difference. And so I thought that was absolutely fascinating and really highlighted my lack of knowledge. Really? And then with some of the evaluations were quite funny, actually. Like one of them was, after 20 years, I now know how to use a piezo tip.
Well, it's a bit like me, and it's more than 20 years. So there's not, you know, I'm with that person.
Yeah, but it's just, I suppose, with the machines and feedback loops, what you're saying, to take that pressure off the joints as well. Yes, because I do see on the forums, there's quite a lot of people, you know, carpal tunnel syndrome.
RSIs, yeah.
Yeah, you know, so just learning how to use this equipment, because they had, you know, they're so efficient now, aren't they? You know, compared to probably what I would have trained with, or maybe perhaps what you would have trained with.
Oh, for sure.
So, and then we had the air polishing. What did you
Yes.
think of the air polishing?
The air polishing is great. Actually, one of the things I thought was fantastic about the course was the the egg and the candle and all the rest of it. I thought they were great because they trying to remove the stain off things and showing how different angles affect, sometimes you can have that air polishing thing blasting away, but if it's too close to the thing, it's really only sort of touching a point. So by utilizing something as simple as a little egg, it really helps you to see what angle you really need to be using it at, and the distance, because too far away, clearly it's no good to you at all. But, again, when when you're working and you're desperately trying to achieve something, sometimes it's a bit like with the scalers, we hold them too tightly, we tense up all our muscles, everything,
Yes.
and we think that just, brute force is going to manage this, when of course it isn't at all. And so in the same way with the air polisher, by almost blasting the thing too close to it, we somehow think that this is going to work better. But when you look at how that happens, you realize that's actually completely the wrong approach. So again, I thought it teaches you how to use these things in the most almost light-fingered, creative way, but you're achieving more.
Achieving more and having your body nice and relaxed.
Yes.
Yeah, because years ago I was just thrown an air polishing device. When I think back about it, there was not really any training around that time years ago.
No, but I don't think that, but also the expectations for those things were different. It was just a case of blast a bit of stain away.
Yeah,
and
rather than biofilm removal.
Yeah, there was no concept of the biofilm. There was no concept of, its role in anything other than stain removal. And yes, it removed the stain from the chair as well as everything else by the time you clean it.
It's like kind of a facial as well for us. But, oh my God, and you could taste it and everything.
Yeah, it was brutal. It was incredibly rudimentary. And yes, and so the concepts have changed. So the tools are following the concept in a way. So the concept of biofilm removal, rather than, gouging bits of the tooth out, have enabled these bits of kit to come along and to be used in a much more gentle way. If you were using air polishing on somebody 4 times a year in that old-fashioned way, I think it would be actually quite destructive in a way. But this is so gentle. And also, it's used in a different way. You're away from the gingiva. You're not going to end up sort of abrading the whole gingival margin, which you could easily have done with those old-fashioned... With
those old powders. And which also is really important to understand what powders you're using. So subgingival powders, largely I just use subgingival powders for everything now, because why not use a nice talc-like, keep your patient nice and happy as well, and also healthy. But rarely do I pick up a supergingival powder any longer.
Perhaps if somebody had ortho bands on and they hadn't kind of cleaned their teeth, maybe they might need some of the supergingival powders, but the subgingival powders are actually very effective at stain removal.
Absolutely fantastic.
Yeah. And that's what I'm saying. If you use the right angle and the right distance, you can actually be very effective and not try and overcompensate with bad technique, because it's not going to actually help.
Not going to help.
Yeah.
And moving on to your lectures that went down fantastically, Ros.
Yes.
So I know in the UK you covered the direct access as well. In Ireland, unfortunately, we don't have direct access. But you were looking at, treating perio in practice and our role within that. Tell us just a little bit of an overview about that presentation, please.
Well, the presentation on active hygiene management is a little bit like I was talking about in the beginning. It's not a lecture about what to do. It's not a technique lecture. It's a lecture to look at the patient journey and how they are managed, from initial presentation to treatment, to reassessment, to hopefully maintenance. And it's to look at the hygienist's role in that and what they should, what we can expect them to be able to deal with, and what may not necessarily be within their remit, and what they might have to reach out and ask other members of the team for help. It's also for them to understand their duty of care. They need to understand rules and regulations around where they are being governed, how somebody from outside would view their treatment planning process. Because I say to everyone, not every treatment plan goes well, not every treatment plan works, not every tooth is saved. But if you have made a proper diagnosis from the outset, you have a good idea whether it's likely or otherwise. The patient is in on the whole process, and you can have an expected outcome. And if that is where you expected it to be, great. If it's not, then we need to be reflective about, is it us? Is it the patient? Did we not control for various things? And so rather than kind of blindly saying this patient has periodontal disease, I'm going to do X, and then it's just going to go to maintenance, or it's, wherever it's going to go back to 6 months. That is sometimes the case. But if then, as an external examiner, look at it and think, why have you put this patient on a 6-month recall when the patient has poor oral hygiene or whatever, or a mouthful of 6mm pockets? Would you not have felt that that was still unstable? So it's to be able to look at that whole process and reflect, reflect at the, look at it at the beginning, see what you can expect, talk to the patient, get them involved, and then reflect back and see how it is. And my biggest issue, I think, with sort of hygiene management is that sometimes they lack that sort of reflection. And I do remember in one lecture asking people, I can't remember exactly what it was about, and now you're going to bring this patient back in 6 months' time. And I said, well, what are the factors that would determine whether this patient should come back in 6 months' time or 3? And I didn't feel that some of the times those answers were clear-cut enough. And there are a myriad of answers. But I didn't feel that everybody was kind of super clued in to the factors that determine stability or not stability, an engaged patient, and I'm not a fan of the term, but you know what I mean, a non-engaged patient, and how this is going to be managed ad infinitum, because that's sometimes the problem, not the treatment itself, it's the maintenance.
Yes.
And we see patients, and medical legally see patients, and they've been saying, I've been seeing a hygienist every 3 months, 4 months, 6 months for the last 5 years, and now this. And that is disappointing, because either the hygienist isn't aware, either the hygienist is doing their best, but they know they're not getting anywhere, but they don't have the confidence to do something about it. And that's where I come in. If you have the confidence to understand that this isn't going where you feel it should be, then it's time to make a change. So it's to get off that treadmill of, I'll see you in, even if it's I'll see you in 3 months' time, I'll see you in 3 months' time. At some point, you have to sit back and think, is this okay? When was the last time we had a radiograph of that lower left 7?
Yes.
Because, and especially things like with furcation involvements, you can be probing those all you like, but you've no idea really what's happening on, you don't, And sometimes you take a radiograph and you think, oh my God, it's gotten so much worse, and I didn't know. And this happens to all of us. But if the patient goes to another dentist and says, another practice, and I've been seeing the hygienist, blah, 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 and then they take some radiographs and things are so much worse, and you had no idea, then that is a problem.
Yeah. And the feedback has been that people have felt a lot more confident to bring these cases back, to, readdress the whole situation, call the principal, the associate, the referring dentist, or if it's direct access, to reach out to the periodontist, which is something I would like to touch base with you today. Yeah. The relationship with the periodontist is very important, your local periodontist, and it's something that people sometimes don't know how to address. I personally, when I relocate, would touch base with the local periodontist and meet them or have a chat with them and say, what do you want from me? I think I'm probably pretty good at knowing when to refer, but sometimes it's, what does the periodontist want from me as a hygienist? So I think I remember, Ros, you like to see the patient before they we even touch them. You just wanted some oral hygiene instruction done, didn't you?
Yeah.
Where some
Yes.
periodontists maybe want some form of debridement done first. What's your thoughts on that?
Well, for what I would prefer to avoid is somebody coming to me and saying, I have seen the hygienist for 4 times and I've done this, that, and the other. And then I take some radiographs and I think, okay, there's still some calculus there, so I'm going to start to do something, not the same, but similar. So that to the patient, they sort of think, I've just been seeing the hygienist. I've seen the hygienist multiple times. So I think to avoid that, and again, nothing is black and white. You see a patient and you make a judgment as a hygienist that I can manage this, or, it's 50-50 or not a chance. So not a chance, oral hygiene instruction, send it to me because we're going to have to start. I have a good chance of getting this, then why would you be doing anything other than your level best? You talk to the patient. The 50-50 ones will often depend on if it's a young patient, if you don't feel you have enough radiographs, if you would really like, you're a bit worried that this isn't kind of where, is there something else going on, et cetera, then I think a discussion with the patient is your best bet and say, well, we can do this, but then, the usual. So again, and I've overused this word confident, but a confident hygienist will know what's well within their remit. They will know what's well outside their remit. And the in-between bits can vary. But I think that if you are knowledgeable going into that, you have, and take the patient along with you, then it's easier to say. But no, I don't want somebody who has a mouthful of 10mm pockets, having seen the hygienist for, 4 to 6 times. And then I'm going to look at it and think I'm still going to need to do some debridement, et cetera, because they will look at me and say, well, I've just seen her. So that I think is, because, and yes, you want to sort of say, well, what's the difference, et cetera. But it's best to kind of avoid that. Whilst if you can, as a hygienist, get it to a point where they had a mouthful of sort of 8mm pockets at the beginning, but now they only have 2 or 3 remaining, then that's much easier for me to say, whatever. But then if there's still a lot of calculus visible on new radiographs, then we're back to square one. So again, how confident are you? How good is your initial information? I mean, I keep going back to this. What are your radiographs like at the beginning? Because you might be working off a couple of bite wings. And, the distal of the lower 7s are not going to be anywhere near visible, or the anterior teeth are not visible, or whatever it is. So you can still do the best you can. But for me, yes, I would prefer, if you think it's a severe case, just to refer it. But if you think you have a good chance, get on and do what you can. And if there's a couple of bits left over, then we can deal with them.
Yeah. One of the situations that I've come up with the local periodontist is I suggest the patient that they go for the treatment plan, that I will probably be involved in doing some of that treatment and she'll be involved. And I get a lovely, very clear letter back saying, Siobhan, the dentist's name and what she's going to do. And we all know what our part in this is. And it works really well. Maybe that's something that if somebody else, another hygienist or therapist wanted to suggest that to their local periodontist, that might work too. Now,
I agree. And if you know that, so when I used to work in a much bigger practice, I worked with some hygienists for many, many years. And and sometimes I would be referred cases by the dentist and I would think, I think that, this is well within the remit of one of the hygienists here or whatever. So instead of me seeing the patient, I would actually send it to the hygienist and say, here's the charting, here are the radiographs, this is what I want you to do. So, and even now in the practice I work in, if I feel that, because like some dentists will refer cases that are not necessarily that advanced, and so I sort of look at it and think, what is the value of them seeing me when I know that there's a very good hygienist who can do that? And I think hygienists would be much better if they had all the information to start with. So when your periodontist refers back to you, you get all the information to start with. And so you're moving from a position of power rather than a position of a lack of knowledge. and that's where I keep going back to again and again. Where are you coming from? Are you kind of sticking your head up above the ground and saying, I'm doing the best I can, I'm doing the best I can, but I don't really know what I'm dealing with? Or are you saying, well, now this is the situation, it's this, that, and the other, I'm going to do that, and then I'm going to do that, and then I'm going to reassess, and then somebody else might have to do something else. That's a position of power, as opposed to, treading water and hoping for the best.
Yeah, and it's nice teamwork to do that, isn't it?
Yes.
You do feel more part of that team, and
yes.
It definitely opens up the conversation more for the patient, and the patients love it. They like to be part of it, of this team as well. As I said earlier, co-creating the appointments as well.
Yeah, no, I think it's and also it brings the hygienist role into the mix at a much earlier stage, which is a good thing, because one way or another, the long-term management of this case, whatever the outcome, is going to be dependent on the hygienist-patient relationship. And as I've said it earlier, the maintenance phase, how it is done, what is done, how frequently it is done, the role of the patient, can sometimes be the real determinant in terms of long-term retention of teeth. Some people can do fantastic surgeries and all the rest of it, but we all know the patient who rocks up every 3 months, who does their best with their hygiene, who doesn't smoke, has controlled diabetes, and a hygienist who has enough time and information to be able to get into those residual pockets, because there will always be some, and to be able to devote the time to those and to be able to reflect on how they're doing.
Yes.
Those cases will generally do better. Whilst if it's a kind of, I'm trying my best and just blasting everything in hope that something is going to work, it's a hit and miss scenario. Sometimes it works, but sometimes it doesn't.
And going to your other presentation, just to bring in while we're talking about this, is the pharmacology. And, there's some complex medical histories there with our perio patients, isn't there? And I know you always smile and even when I asked you to do the pharmacology, but it's just an area that we don't get to upskill in, Ros, and, you kind of just sometimes you're kind of wondering to yourself, am I up to date? Do I know what the up-to-date evidence is? Where do I go and look for this? And that's what was really helpful about your presentations. And the evaluations really did come back to say that we were right to do that,
Well, I think it is, okay, it's one of my pet subjects, so it's not, I have I'll confess to having an interest in pharmacology and have always read it. But I am often horrified by and I'm not talking about hygienists, by some dentists' lack of knowledge as well, in both the sort of complex medical histories that they're treating, but also how it can impact the patient's sort of oral health as well. That's very varied. Now, hygienists are much better clued into the role of, health, oral health and systemic health. I think they are pretty well aware, actually. Well, some dentists really aren't. But again, as I will often say to them in the lecture, what do you say to a patient when they have these complex medical histories? Because my big thing about all professionals is that we are professionals. And therefore, when you stand in front of a patient, you want to act like a professional. And a professional has knowledge. And so when a patient says to you, I'm taking X, Y, and Z, rather than you going, okay, where, like, does anybody know anything? You can then turn around and say, oh, so, you have blood pressure, is it well controlled, blah, 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 how are your diabetes, when was the last time you was checked? You ask information about it, because but you can only ask information about it if you have some knowledge. So somebody sort of says they've just finished chemotherapy or whatever, and you, instead of kind of go, okay, and just putting it in the notes, you sort of, you can talk to them about what stage they're at. Are they still seeing the multidisciplinary team? Do they have any dry mouths? Do they, all of those things. And if as a professional, you ask professional questions, I think that the patient views you very differently. Or if somebody is about to start chemotherapy or they're about to start treatment on bisphosphonates or whatever, if you off your own back come out and say, well, now there is a low risk, but this, that, and the other, that, then we want to try and avoid extractions. We really want to keep your mouth as healthy as possible. So I think we need to go into overdrive now before you start this. I think that works so much better. And how the patient perceives you as the professional really goes up. You are a fellow professional. Yes, they're seeing some medical people, but they're seeing you to try and make sure that their mouth is so healthy that these drugs are not going to cause them major problems down the line.
Yes, and there's that point of contact now. I don't know if you have that in the UK, but here not. Yeah, so it's another point of contact, isn't it, for picking that up with the patient as well? Yeah.
And it's also telling patients that my role is not just cleaning your teeth.
Yes.
We have to move away from that. Yeah. Because that's where the time thing, just clean my teeth type thing. You are a dental hygienist therapist, of which your role is to clean teeth, but it's to educate you about oral health, your oral health, how that relates to your general health, how certain bits of your systemic health or medications could impact your oral health. And your role as an educator is there to tell patients, because some patients, are put on bisphosphonates by their doctor, and they have never been told that it could possibly ever have any effect. Some are put on amlodipine without ever being told that they could get gingival hyperplasia. So you, as the point of contact, are the person to say, oh, I see you're taking amlodipine. What dosage? How long have you been on it? Let me have a look. There's a risk of this, that, and the other. And so you involve the patient in their oral health. And it makes your job more interesting, but it also really improves your standing in how they see you, rather than just, clean my teeth.
Absolutely. Absolutely. So where is the future? And everybody keeps often asks me ikigai, or they can't pronounce it or whatever. And just a little bit about exactly it. What is it?
I know you explained this before, but okay, in a nutshell.
Yeah. So, in a nutshell, well, there are 5 blue zones in the world, and lifestyle medicine are really looking at these blue zones. But, they live to be beyond 100. But when they live to be beyond 100, they live in full health. So what they went to these areas and had a look, and it's all to do with, physical activity, nutrition, social support, and so on. So, I keep going back to this social support, but in one of the areas in Japan, in Okinawa, they have this thing called ikigai. And ikigai is your purpose, why you jump out of bed in the morning. And when Gemma O'Callaghan and I first seen the Venn diagram, what do you love? What does the world need? They say in the Western world, what can you get paid for? In the Eastern world, don't like that. They say that they see that more as an energy back. What are you really good at? And then in between that is your mission, your passion, and vocation. That really hit me, because I think within dentistry, it really is a vocation, isn't it? We are so passionate about looking after our patients and making, for prevention and keeping them in full health. And so Ikigai, really the oral hygiene program, is about, again, that upskilling, but keeping that supportive network. And there's lots of educators and mentors, particularly for new graduates, if they want to reach out and speak to somebody. And it's about giving people a platform. If they're passionate about something, they can reach out to us. We'll be delighted to give them a platform to do a webinar, a course, and just keep evoking those passions within us as a profession, because there's lots of people that are doing hygiene or therapy, but they have their little specialities, which I think is amazing, isn't it? Or as Susie once said, all you dental hygienists and therapists all have side hustles. maybe it's to kind of keep us sane as well. So that's really what Ikigai is.
Okay. So it's like a team support for hygienist therapists and looking after, it is, I suppose it's like to encourage everybody's development, and at the same time do a kind of looking after them as well. You want to look after the team and everybody and encourage them to be the best they can be. So it's like being a parent. You want to sort of say, come on now, we can all do better.
Yes.
And at the same time, when they're upset, you say, oh no, don't mind, don't worry, that's fine. We've all had these issues and this is how we resolve them. And I actually think that that's almost like the best way to look after people, because we have to kind of almost coax each other to do better. You know, it is quite
Yeah.
easy to sit back in your laurels, but then you look at other people and then they kind of enthuse you and you think, okay, I need to make an effort. But I think more than anything else is as well, when things aren't going so well, that you have people that understand and can kind of help you get through difficult bits, and to not feel that it's all your responsibility, because dentistry can be a very lonely profession.
Very lonely. I've often felt very isolated.
Yeah, it can be very lonely, and patients don't understand how much responsibility we take for their care. You know, okay, I'm past the point where I can remember people's names anymore. I used to be very good. Now I don't. But still, once somebody's in the chair, or what, you know, we all remember those cases that don't go well, you know, or, you know, and we dwell on those patients who said we were a waste of time, or, you know, we dwell on all those kind of negativities, even if 95% of people say, oh, I think she's great, and, you know, really do their bit. We often focus on those negative things. And so if you are not in a supportive environment, if you are kind of, you know, a dental therapist, hygienist working in an environment where you don't have a very supportive practice, and you have a couple of days of just kind of yuck, bad sort of feedback or negative things or things happening, it's very easy to get downbeat about that and to think, oh, it must be me, I must, you know, whatever. Whilst if you're part of a group where you sort of can say, look, I had a really bad day, somebody came along and this happened or that happened, and this person, whatever it is. And for other people to reach out and say, don't worry, I've had far worse days, etc., etc. You know, it makes you feel better because it's coming from a community that understands. There's not much point in you going home saying to your other half and they say, no, you know, they're there, it's fine. You think you don't understand, you know, you aren't there, and you don't think. So that support within the profession can be vital for some people, especially those that are a bit isolated or a little bit less confident. And they're the people we really would like to drag out to these courses, to meet them in person, to kind of, you know,
empower, lift up.
Yes, exactly.
In the positive psychology world, they say, you know, everybody has the right to be lifted up to a higher level. Yeah, that it's everybody's human right to do that. Yeah. And definitely the feedback was that we did achieve a lot of that from the courses, which, you know, that was our aim, because we had aims for these courses, and we're going to continue. We're going to be back around the UK and Ireland over the next year. So we'd be delighted for you to come and join us. Oh, that would be lovely. I've really enjoyed it. As you say, it's a series. It's a program. This was a kind of year one into year two. And so, and again, if we get feedback about what people really want to know about, that would, you know, that would be great. What kind of topics do they want? Yes, keep giving us the feedback. Yeah, as you say. And actually, one of the things this year we're really going to focus on is implant maintenance for the dental hygienists and therapists. And we've got Catherine Mayo and Jenny Walker. They're really passionate about implant maintenance. Great ladies, aren't they? They are. They're knowledgeable, because again, implant maintenance is one of those things where everyone kind of almost backs off and think, oh my God, I don't know what to do. I don't know what to do. And that's partly because the profession itself hasn't known what to do, and probably in truth still doesn't know what to do. But those girls have been doing it for such a long time that they can sort of talk from experience. Lots of dentists and hygienist therapists don't have enough experience, but it is the coming thing. I mean, more and more patients have implants, will have implants. So having the confidence to know what to do with an implant is going to be really challenging, I think, for the future. And certainly the sort of thing where hygienists really need to upskill. And even if that's to bat it back and say, that's completely outside my league here, because that I really see that as being a problem, because nobody seems to want to get involved in implant problems. And you don't want to be kind of dumped with patients with failing implants from a sort of hygienist perspective, and then left to kind of get on with it. So if nothing else from this course, it would be a case of when to say absolutely no way is this a hygiene maintenance issue. And
and that, I think if we could even get that right, I think that would be amazing. You know, learning what to use around there would be even better. But that's the first thing.
The first thing, and they've an absolutely fantastic course put together. I'd highly recommend it.
Yeah, exactly. So that'll be great. I look forward to that.
I look forward to it. Yeah. Well, Ros, it's great catching up. And we look forward to meeting you all out there across the UK and Ireland over the next year. As Ros said, please reach out to us if there's any topics you'd like to see covered. We'd be more than delighted. So thanks very much, Ros.
You're welcome. I really enjoyed it.
Thank you.